Good afternoon. I would like to welcome you to our 9th CLL Care webinar, an educational program designed for healthcare professionals worldwide. The goal of this series is to provide hematologists with a comprehensive, up-to-date overview of the latest advances in CLL management. Today's session is dedicated to the topic Navigating Target Therapy in CLL Best Practice in Treatment Sequencing. Before we begin, please ensure that your microphone is muted and your devices are silenced. I encourage you to submit your question to any time using the chat box, and we will address them during the discussion segment. Also, it's my great pleasure to welcome Dr. Othman Al-Sawaf, medical oncologist at the University Hospital Cologne, Germany. Dr. Al-Sawaf's research focuses on cancer evolution and tumor metabolism with a particular emphasis on CLL. He applies advanced computational approaches to develop and refine innovative treatment strategy in clinical oncology. Objectives of our webinar are to review current target therapies for CLL, including BTK and BCL-2 inhibitors, anti-CD20 agents, and combination strategies, to explore resistant mechanism and treatment sequencing after failure or intolerance with practical guidance for BTK and or BCL-2 inhibitor exposed patient, and also to highlight emerging therapy and future directions such as non-covalent BTK inhibitors, CAR-T, bispecific antibody, and novel agents. And now I'm pleased to hand the floor over to Dr. Othman Al-Sawaf.
Right. Thank you, Maria, for the kind introduction. So I will continue with the presentation. And as you know, we've had a lot of developments in CLL over time and a lot of new compounds being developed. And the major advances in the field have been typically introduced first in the relapsed space and then later on moved into earlier lines in the first-line setting. And this is largely based on the fact that over the past 2 decades, we've really understood the distinct vulnerabilities that CLL has in a much more granular way by understanding key pathways on which CLL proliferation and survival is dependent. And so disrupting these pathways or interrupting these pathways has become a major strategy by which we can control disease in different ways. And naturally, the field is also evolving to new strategies, new molecules, and new targets that we can use, again, for patients who experience disease relapses, since probably all of the different targets shown here do not lead to cure for most patients with CLL. So therefore, salvage strategies will stay relevant and important also in the future. Importantly for relapse disease, what's important to bear in mind clinically is that even when we see patients who progress, let's say, on a continuous treatment or after a fixed duration treatment, if they are asymptomatic and do not have any complaints, then the patients do not need a new line of therapy until they really fulfill the criteria of symptomatic active disease as defined in the ADU-CLL guidelines. So this is very similar to the first-line setting, but we know that early treatment intervention does not extend overall survival, and similarly, we don't have any evidence at this point that an asymptomatic relapsed CLL requires any therapy or that it extends overall survival if we treat it earlier on. And one point that is becoming relevant, though, is the molecular testing. So we know that some genetic variants can be acquired after therapy or during therapy, and therefore repeating the baseline tests for somatic mutations is important also when reintroducing a therapy, not necessarily to choose a treatment, but to know whether the prognosis has become worse than before or the disease has become more aggressive than before due to clonal evolution. And when it comes to the options that we have in the relapse space, we'll quickly go through the different approaches that are most established at the moment. They range from targeted therapies, in particular BTK and BCL-2 inhibition. PI3K inhibitors did play a role to a certain degree for some time. And of course, historically, the role of chemo monotherapy, which was used in the past, as well as newer approaches related to novel approaches to target specific molecules, but also cellular therapies as an option. Let's have a look first on chemoimmunotherapy. And here this has been shown now in multiple trials that chemoimmunotherapy in the relapse space does not produce long-term remissions or good disease control. So you can see on the left from the Murano trial a comparison of the BCL-2 inhibitor in blue against chemoimmunotherapy with bendamustine rituximab, where you clearly see an inferiority both in terms of PFS as well as overall survival. And on the right, you can see the data from the ASCENT trial, which tested continuous acalabrutinib compared to a choice between bendamustine or idelalisib. Essentially, as you can see in the lower two curves, the green curve indicating chemoimmunotherapy, where you see a very short overall median progression-free survival of less than 2 years with chemoimmunotherapy. And so we can see that the role of chemoimmunotherapy in the relapse space is not existent anymore. There is no indication or any setting in CLL nowadays where a relapse disease should be treated with chemoimmunotherapy, even in the context of mutated IGHV or other indolent forms of CLL. And so if you look at the ESMO guideline that is currently valid, you won't see any mentioning of chemoimmunotherapy in the blue boxes below. It's all around targeted therapy or even cellular therapy for these patients. And when you look now into the NCCN guidelines, you see that their main distinction for relapse disease is based on presence or absence of TP53 alterations as indications for how aggressive the disease really is. And the choice that we eventually make is really based on particularly the prior line of therapy. And for this, it's relevant to consider what we have in terms of randomized evidence in the relapsed space. And here we, first of all, have most of the data generated for continuous treatment strategies with BTK inhibitors that originally compared to chemoimmunotherapy or to CD20 antibodies, but now more and more data are being generated comparing different BTK inhibitors to each other in the relapsed space. The BTK inhibitor that has been in use for the longest time now has been ibrutinib, and here we have 6-year observational data from the original RESONATE study, which tested continuous ibrutinib in patients with relapsed disease, and where you can see that even in heavily pretreated patients, a decent median progression-free survival of almost 4 years was observed, including in patients who have TP53 alterations. So this is one of the longest observations that we have in the relapsed setting. And importantly, this also, of course, shows superiority to CD20 antibody monotherapy with ofatumumab, of course, a comparator that hasn't any relevance nowadays. But it essentially demonstrates on its own that ibrutinib has this long-term efficacy and ability to control relapse disease for a long time. And naturally, we are moving away from these approaches, given that we have now second-generation BTK inhibitors, including acalabrutinib, which was originally developed in the relapsed setting by comparing it to a PI3K inhibitor, idelalisib, or bendamustine rituximab, investigator's choice. And this ASCENT study, as I mentioned before, showed that continuous treatment with acalabrutinib leads to a longer progression-free survival and controls the disease, therefore, much more effectively than PI3K inhibitors or chemoimmunotherapy. And notably, this is again applicable also to TP53 and unmutated IGHV status. So those patients who have higher risk disease also tend to benefit from the continuous BTK inhibition. And then we have another study, which was the first head-to-head study in our field on testing different BTK inhibitors and comparing them to each other. And as you can see on here, the ELEVATE-RR data are plotted in relapsed refractory CLL, comparing continuous acalabrutinib to continuous ibrutinib, with the primary hypothesis that acalabrutinib is non-inferior to ibrutinib in terms of progression-free survival. As you can see on the right, this hypothesis was clearly confirmed in the ELEVATE-RR study, but while it has the same efficacy, it has much less toxicity than ibrutinib. So this was demonstrated Here, where you can see across all sorts of side effects like diarrhea, but importantly, cardiac events, including atrial fibrillation, were significantly less frequent with acalabrutinib than with ibrutinib. So that in of itself is a clear indication that acalabrutinib should be preferred over ibrutinib when administered as a continuous treatment like here. We also have another second-generation BTK inhibitor and data from a head-to-head study that was published a little bit later than ELEVATE-RR, the ALPINE study, which also focused on relapsed CLL and demonstrated that zanubrutinib is better tolerated than ibrutinib, but also potentially more effective to a certain degree, suggesting really that also zanubrutinib should be preferred over ibrutinib in terms of continuous treatment. And in particular, again, the most important side effect of ibrutinib around cardiac disabilities or disorders, this is much better controlled by using zanubrutinib, by having less atrial fibrillation events in particular compared to ibrutinib, which is why all guidelines nowadays recommend using one of the second-generation BTK inhibitors like Icala and zanubrutinib over continuous ibrutinib. And so eventually all of these studies shown here, RESONATE, ASCENT, ELEVATE-RR, and ALPINE, validate the continuous BTK inhibitor approach in the relapsed space, including in high-risk disease. And especially if you look around here, while the follow-up varies across the different trials, you can see that all of them suggested, as you can see from the hazard ratios for PFS and overall survival, a clear advantage of having a second-generation BTK inhibitor. Alternatively, and in some ways similar to the considerations in the first-line space, we also have the option to use a fixed duration strategy. And at the moment, this is only one option that we have, which is venetoclax in combination with rituximab, administered for overall roughly 2 years as a fixed duration treatment. This is based on the comparison of this fixed duration approach to fixed duration bendamustine rituximab administered over 6 cycles. And in this study, again, focusing on relapsed refractory disease, it was observed that the progression-free survival of fixed duration venetoclax rituximab is significantly longer, and also the overall survival is longer with venetoclax rituximab than with bendamustine rituximab. So this is indicates really that what we don't necessarily need to treat for multiple years to get patients under disease control, but that 2 years of venetoclax with initial 6 months of rituximab can also provide very favorable long-term outcomes. But as you can see from the PFS curve, most patients at some point still experience a PFS event. So therefore, again, this is not a curative approach or the final approach to control the disease, but it is one part of the strategy that we have to control CLL. Notably, the Murano study also has a retreatment program that is so far one of the few prospective data sets that showed that if a patient who has received venetoclax rituximab in that trial experienced then a symptomatic progression and is put on venetoclax again, that these patients have responses for over 70%, and that the median PFS for these patients is around about 2 years. So these were highest risk patients that experienced this kind of disease progression and were put then on venetoclax again, which suggests that the re-exposure to venetoclax is a feasible option for patients with relapsed CLL following fixed duration treatment. And then we have now a newer development, which is around also targeting BTK, but in a different way. And for this, we have now more and more data generated on non-covalent inhibitors of BTK. And for this, we have in particular pirtobrutinib, which in the meantime has been also approved for treatment of CLL or relapsed CLL. And this is really based on the one hand, on being more selective for BTK and having therefore less off-target inhibition compared to other BTK inhibitors, and also due to its pharmacological properties, it is able to stabilize BTK in a closed inactive conformation, and therefore even when you have presence of certain resistance mutations, pirtobrutinib pharmacologically is still able to disrupt BTK signaling. And we have data largely from a large phase 1 study that was run in patients with CLL, the Bruin study. In this study, patients with previously treated CLL were enrolled and received pirtobrutinib monotherapy as a single agent. Importantly, there was also a subgroup of patients that had all received prior BTK inhibition with a covalent inhibitor, and also a large fraction who received BCL-2 inhibitor. So really heavily pretreated and also exposed to other targeted agents. And despite that, we can see that most patients do respond to pirtobrutinib, even when resistance mutations on the BTK gene are present, and also the median progression-free survival in this phase 1 study was more than 19 months, showing that even in this heavily pretreated context, we get a good progression-free survival. In fact, in double-exposed patients who had received both a BTK inhibitor and a BCL-2 inhibitor before, we still see sustained efficacy of approximately 17 months median progression-free survival. So again, not a final long-term solution, but at this point, the most effective strategy that we have for patients who are double-exposed. And we have also seen that in this trial, the side effects of pirtobrutinib seem to be quite favorable, in a sense that the cardiovascular toxicities that we are so concerned with when it comes to BTK inhibitors are very infrequent. So the rate of atrial fibrillation or hypertension were extremely low. This is not a head-to-head study, so we can't compare this to ibrutinib at this point, but generally when it comes to the toxicity signature, it seems that this is quite favorable. The only side effect that is quite common and probably related to an on-target effect on BTK are the bleeding episodes. So if you look in the table in the lower rows, bleeding and bruising are occurring in over a third of the patients, even though they are all low grade, as you can see, or largely low grade. It is still a side effect that is frequent also with pirtobrutinib, despite its non-covalent properties. But again, this is probably an on-target effect because BTK is also expressed in thrombocytes and has a role in platelets or in platelet aggregation. Moving on to patients who are exposed to venetoclax, which nowadays are very frequent patients who have at some point received venetoclax for earlier lines of treatment and are later then considered for a non-covalent inhibitor. And here, again, from the Bruin study, if you look at the subgroup of patients over 100 who do have an exposure to venetoclax before, you can see that the median progression-free survival for these patients is 16 months. So this naturally means that the patients have a shorter PFS than when they are venetoclax naive, probably not specifically related to venetoclax, but more to the fact that they have been exposed to more lines of therapy or have exhausted more effective lines of therapy. And therefore, this is a pattern that we see with many studies where we see the more exposure the patients have to prior therapies, the shorter the PFS eventually is. But it means in practical terms, when you have a double exposed or even a double refractory patient, that they can expect disease control for at least 1.5 to 2 years with a single agent treatment with pirtobrutinib. And in addition, we now have also randomized evidence on pirtobrutinib. This is again in patients who are all exposed to prior covalent BTK inhibitors. So this was a main inclusion criterion. So all of the patients had to have exposure to continuous ibrutinib, acalabrutinib, or zanubrutinib in earlier lines, and were then randomized to receive either pirtobrutinib as a non-covalent inhibitor or receive, again, investigator's choice of idelalisib, rituximab, or bendamustine rituximab, similar to what you saw before from the ASCENT trial, although in a very different patient population. And the study eventually confirmed that the treatment with pirtobrutinib is more effective, leads to a longer progression-free survival than the PI3K inhibitor or the chemo monotherapy. So this is a clear sign that pirtobrutinib for patients, especially when they are double exposed, should be the preferred option to reinduce a remission or achieve disease control in double refractory disease. We have an alternative approach to pirtobrutinib when it comes to double refractory disease, and that is CAR-T cell therapy. So CAR-T cells have been now established for many years in our field in lymphoma and leukemia. In CLL, the data are still sparse, but general principle of using autologous T cells to induce anti-tumoral activity has been validated and well established for many years now. Importantly, we have one data set that is most mature from the Transcend study, which has different stages and different phase 1 and 2 components, but generally it tests lysocell, a CD19 CAR-T cell therapy, in patients who have relapsed or refractory CLL, and the study showed that especially in patients who do achieve a good response to the CAR-T cell therapy within 30 days of infusion, that these patients actually have excellent outcomes. So if you look at the two upper curves, both the patients who achieve a complete remission, but also those with partial response achieve a good progression-free survival. Overall, though, the efficacy of the treatment in double refractory or double exposed patients is in the range of a year median progression-free survival, so along the lines of what we achieve with pirtobrutinib as well. And therefore, at this point, the sequencing or the choice between using a cellular therapy or the non-covalent inhibitor is a little bit open for double refractory disease and more driven by practical and operational implications rather than really the efficacy, which seems to be overall comparable. Of course, CAR-T cell therapies are more complex and eventually also more toxic than single-agent BTK inhibition. But still, it shows that there is still some work to do in this space because we don't have the ideal answer for this group of patients yet. So let's say we are aware of the treatment options that we have for relapse disease. We know there are BTK inhibition as continuous strategies with covalent or non-covalent inhibitors. We have fixed duration options with BCL-2 inhibitors, and we have also the option of potentially using cellular therapies for relapse disease. What factors should drive us in our decision making? And there are, of course, some very pragmatic aspects. So, of course, we should think about what kind of prior therapy did the patient receive. So not just first line, but also maybe a second line treatment. What kind of exposure did the patient actually have? And also, did the patient really progress on or after the therapy, or did they just discontinue the treatment because they tolerated it poorly and then had an early progression? These distinctions are very relevant because they define whether or not the patient is really just exposed to a specific therapy or whether they are really refractory to a specific therapy. And naturally, high-risk features are still relevant also in the relapsed disease. A patient who does carry or acquire TFD3 alterations will always have a worse prognosis than someone who doesn't. Comorbidities are, of course, still relevant. The concomitant medications, naturally, the preference of the patient in terms of fixed or continuous or cellular therapy are extremely relevant. And along the same lines, the age and the fitness of the patients. And so, given that we don't have any head-to-head data comparing, let's say, venetoclax rituximab to continuous acalabrutinib or so, we have to make the decision between the fixed duration and the continuous treatment option really based on the advantages and disadvantages that apply for each individual patient. And so naturally, as demonstrated here, the continuous therapies do have some advantages in the side effect profile, but also in terms of how elaborate the medical supervision needs to be to ensure treatment adherence and efficacy. Naturally, though, it again requires a lot of patient compliance for multiple years because BTK inhibitors only work when you give them a single agent at least continuously to control disease proliferation. And with the fixed duration options, similar to what we have in the first line setting, if you have a preference or patient that prefers short therapy, if you have a patient that really is keen about having treatment-free intervals, then the only option really is to use a fixed duration therapy, which granted is at the moment in relapse disease quite long with 2 years, so longer than what you do in the first line space. So therefore, again, this needs to be weighed or discussed with the patient how valuable are 2 years of treatment compared to multiple years of being off therapy. In the first line setting, we also have, of course, the consideration around, in the first line space, we also, of course, have a lot of options that we can consider in terms of fixed duration and continuous treatment. And the guidelines, therefore, strongly consider what kind of specific prior therapy the patient had received, and what kind of refractoriness or resistance the patient might have acquired since the first-line therapy. And so, as for instance, the ESMO guidelines use, as quoted here, the ESMO guidelines use the prior therapy as the main stratifier for deciding between the different treatment options. And so if you have a fixed duration option, which includes chemomonotherapy, or if you have a late relapse following venetoclax-based therapy, so let's say you have administered venetoclax obinutuzumab as a first-line treatment, and the patient was in remission for, let's say, 4 or 5 years, which is the majority of patients who receive VEN-O, then you should, as a primary consideration, consider re-exposing the patient to venetoclax again. And typically here you can use then the Murano regimen of venetoclax and rituximab. So given that venetoclax obinutuzumab has not been prospectively tested in the relapsed space systematically, unfortunately we have to apply the Murano schedule with 2 years of ven with rituximab as our only fixed duration option. Naturally, there are studies ongoing that explore the use also of VEN-O and other combinations for retreating the patients in a literal sense. And alternatively, of course, we can, especially in those patients, consider putting them on a continuous BTK inhibitor until progression. But I think the retreatment idea or concept is really key in the whole paradigm of fixed duration treatment, because with fixed duration treatment we can avoid treatment resistance and refractoriness and therefore maintain all other options while making most out of the specific mechanism of action. And this brings us to the BTK inhibitor therapy. So if you have a progression on a continuous BTK inhibitor as shown below, then you have 2 options. If you have a true progression on the ongoing therapy while the patient is on treatment, then you have to switch the mechanism of action, because these patients by nature are refractory. So there's no point in switching from acalabrutinib to zanubrutinib or from ibrutinib to acalabrutinib or so, because these patients will be refractory to the BTK inhibitor class in terms of covalent inhibitors. And here, therefore, you have the option to switch to a venetoclax, because these patients would not have a resistance to a BCL-2 inhibitor. But lately also, which the guideline does not include yet, but will hopefully include soon, is of course the option to also switch from a covalent inhibitor directly to a non-covalent inhibitor. For this, we don't have any randomized data to suggest whether switching from covalent inhibitor to venetoclax or to a non-covalent inhibitor is better. And therefore, this is really, again, driven by individual factors, considering whether it would be better for the patient. Let's say they have a TP53 alteration and you want to really keep the patients on a BTK inhibition, then switching from covalent to non-covalent might be a sensible approach. On the other hand, if the patient was on treatment for multiple years and is keen to at some point be at least off therapy, then switching to venetoclax rituximab might be the more sensible option. But importantly, it's relevant to always consider, when you have a progression, did it occur really on the ongoing treatment, or did you give the treatment for multiple years and the patient discontinued the therapy due to non-tolerance or so, and the disease came back afterwards. So for these patients who do not have really a progression on the ongoing treatment, but rather during the treatment discontinuation due to side effects, for these patients, switching to a different covalent inhibitor from ibrutinib to acalabrutinib, for instance, might be actually the most sensible approach. And so this is how, again, the guidelines naturally try to stratify, of course, always as clinical trial as a primary option here. And then for the still relevant group of patients who only had first-line chemomonotherapy at that point, where you can weigh in the continuous treatments with BTK inhibitors or BCL-2 inhibitors with all the ramifications around fixed duration and continuous treatment. When the patients have, and so you can see in the middle column, a progression on continuous BTK inhibition, the switch to a BCL-2 inhibitor, or in the future also the switch to pirtobrutinib might be the most sensible option. And for the first line treatment that is venetoclax based, so either venetoclax obinutuzumab or venetoclax rituximab. Here you, on the one hand, can consider the BTK inhibition, but as you saw before, the retreatment to venetoclax can be considered if the patients had a late relapse beyond 2 years after finishing therapy. Then the primary recommendation is actually to consider venetoclax re-exposure. And so this is a little bit how you can envision a treatment algorithm where it's largely based on the prior line of treatment. So if you have, as you can see, a progression on therapy during the venetoclax intake, then naturally switching to BTK inhibitor is most sensible. If you have a progression after therapy, you can consider retreating, or you can consider switching. And similarly on the right, if you have a patient on continuous BTK inhibitors who has a progression on therapy, then switching to BCL-2 inhibition is the primary choice. If the patient discontinued treatment due to intolerance and then had a progression, then it's worth considering switching within the BTK inhibitor class, because most of these patients are not really refractory, and therefore switching, let's say, from ibrutinib to acala or zanubrutinib is a sensible primary option for these patients. So to conclude on this, we can see from this overview that the treatment selection should be primarily based on patient-specific factors, importantly the preference, but also the distinct vulnerabilities and frailty of the patient. This order of sequences of different therapies is primarily driven by the modality of progression on or after therapy. So it's important to consider whether your patient is the patient truly refractory or just priorly exposed to a specific therapy. Later lines, we have the non-covalent inhibitors and the CAR-T cell therapy as major options, even though especially the non-covalent inhibitors are now being tested in earlier and earlier lines, where they are being considered as also further options, alternatives to BCL-2 inhibitors in particular. And eventually we will need to refine these sequencing strategies by generating more observational and prospective data that guide us in terms of whether a specific sequence of BTK followed by BCL-2 inhibitors or BCL-2 inhibitors followed by BTK inhibitors are more sensible. So to conclude, I'll go now through a clinical case of an elderly gentleman, a 74-year-old patient who had a diagnosis of CLL, originally asymptomatic, would be considered rather fit, so only like mild side effect, mild comorbidities of hypertension in particular, and otherwise normal renal function. So this would not be, in that sense, a CLL14 patient, but more a CLL13 patient, given that the patient is old but fit. And the patient then developed symptoms in terms of progressive lymphadenopathy and rising lymphocyte count. And the genetics that were done when we were considering treatment were the IGHV testing showing intermediate risk due to unmutated IGHV, no TFT3 alteration, no complex karyotype, and deletion 13q as the only abnormality observed. The patient received venetoclax obinutuzumab, and in this case had received therapy and tolerated it quite well. And as you can see here, the patient did show a good response. It was even MRD negative by flow cytometry and was in remission for more than 3 years following the therapy. 3.5 years after end of treatment, the patient showed first signs of progression in a sense of increasing lymphadenopathy, but also an increase in lymphocyte count, and importantly, we did not see new acquired TFT3 alteration in this patient, and the patient was interested when he heard about the option to re-expose them again to venetoclax, given the rather late relapse after finishing therapy. So now you will see a polling question, and the question is, what is your preferred second-line treatment for this patient? Would you switch now to a covalent BTK inhibitor, retreat with venetoclax fixed duration, or switch to a PI3K inhibitor. So once you've completed it, we'll see. Okay, beautiful. So most people would consider retreatment and some would use a BTK inhibitor. Both options would be absolutely right. In this case, the patient was interested in the retreatment with venetoclax rituximab, which was the only approved option for this patient. As I mentioned, the reasoning here is we know that when patients relapse, especially at a late point after venetoclax, that they do not have detectable BCL-2 mutations, and therefore they should still respond to treatment. And the patient had a normal course of treatment, 24 months or approximately of therapy, normal ramp up, no tumor lysis syndrome. The patient did achieve a partial response, and overall, the patient had a remission for a little more than 2 years. The patient never achieved undetectable MRD and on deep level. It was always in the range between 10 to the -4 and 10 to the -2. So it was detected. The patient had detectable disease. And also some residual lymphadenopathy, and therefore not a complete remission as at the first exposure. So later the patient did show up again with symptomatic lymphadenopathy, lymphocytes rising again to over 40,000. And now we have basically our second relapse, or we are in the third line. So what would be now your preferred third line treatment for this patient? Covalent BTK inhibitor, non-covalent BTK inhibitor, a PI3K inhibitor, or a clinical trial. Okay, so clinical trial, of course, is always right if available, and otherwise, within routine healthcare, then covalent inhibitor would be a sensible option, or a non-covalent inhibitor. Both would be sensible to consider. PI3K inhibitor in theory as well, but of course with quite a lot of toxicity and therefore not a preferred option anymore. And of course, one option that would, in theory, also apply, but was not included here, was to do a retreatment with venetoclax again. But I guess most people would be now concerned about the shorter remission. But generally, it would also be worth considering, even though in this case the patient was put on pirtobrutinib in this case. And so the idea was that this BTK inhibitor can be used for patients who are BTKi or BCL2i exposed. In this case, the patient had access to specific access to the pirtobrutinib program, and in this case, the patient was put on a non-covalent inhibitor. Alternatively, the patient could have been also treated with a covalent inhibitor. In this case, both options would have been suitable. The patient received the pirtobrutinib, tolerated it well, had a rapid response, and had a good ongoing partial response with that therapy, and also normalized lymphocyte count and normalized lymph node status. So this is one of the newer options that we now have to use pirtobrutinib, but I would say in this case, similarly, if there wouldn't have been access to pirtobrutinib in that specific circumstances, a covalent inhibitor would have been also equally sensible for this patient. So in this case, the advantages of pirtobrutinib are more extrapolated around the good tolerability that you saw from the phase 1 and phase 2 studies, but equally this patient could have probably safely be put on acalabrutinib or zanubrutinib as a continuous treatment. I think importantly, the patient should switch from BCL2 inhibition to BTK inhibition with a covalent or non-covalent inhibitor. The downside of going with a pirtobrutinib at this point is, of course, that when the patient progresses on pirto now, the question is whether they can be effectively salvaged with a covalent inhibitor. And there are some data suggesting that possibly these patients might become more refractory when they progress on a pirtobrutinib or non-covalent inhibitor due to distinct resistance mechanisms. This was not a primary consideration in this case because the patient was already quite old now at this point and fairly frail, and therefore this is probably not something that has a lot of relevance at this point for this patient, but generally might be one reason to consider more the covalent inhibitors. So with that, I would conclude for now, and if there are any questions or comments, I am very happy to discuss and answer.
Okay. So I would like to say thank you very much for this presentation. It was really great. I was really happy to be here and listen all this, what was sharing now. So how doctors mentioned, the discussion is it's already open. So please, if you have any question, you can write in the chat box. In meantime, we get some question outside of this chat box. I just get it from my colleague and somebody from attendees share with them. So if there is nothing in chat box, we can start here. So first question, what we get from attendee was, in your experience, which biomarkers do you routinely check before starting treatment? Is TP53 or IgHV enough for most cases?
Yeah, that's a great point. And typically the answer is yes. So these are the main variables that determine clinical outcomes with any therapy. And therefore, this should be tested before starting therapy. IgHV naturally needs to be tested only once, whereas T53 should be tested repeatedly whenever initiating a new line of therapy. In addition, what we in Germany and particularly recommend is the testing of the karyotype, so doing stimulated karyotyping to assess whether a genomic complexity exists for these patients in a sense of a complex karyotype with 3 or more chromosomal alterations. This is very meaningful because this is independent of TP53 and IgHV, where this risk, where the presence of complex genomic alterations or multiple genomic alterations is associated with shorter PFS and in some cases even shorter overall survival. The testing is a little bit more complex because it requires stimulated karyotyping, so you need viable cells to do this test, but there are more and more laboratories that offer this at high quality, and there are also ERIC guidelines and best practice papers on how to reliably do stimulated karyotyping or karyotype analysis in CLL.
Mm-hmm. Thank you very much. Yeah, in meantime, I get another question, and it's, in double refractory patient, do you ever still consider idelalisib plus rituximab?
Not really. So we have to say that even if you look at the published real-world data, the toxicity and the efficacy are not very favorable. So we see a lot of toxicity with idelalisib. Personally, the last patient that I treated with idelalisib for CLL had very severe hepatic toxicity and with very little efficacy. And so even the responses are not very durable with PI3K inhibitors, and therefore generally it's become really a last line option. But even in the last line, I struggle to use it, to be honest, because often I just see toxicity without sufficient efficacy. So therefore I would say rather abstain from PI3K inhibitors in CLL at this point.
Mm-hmm. Okay, so next one. For the patient who progressed early on first-line BTK inhibitors, does the change your sequencing approach compared to those who relapse later?
Yeah, to a certain degree it does, because we know that early progression within 2 or 3 years of BTK or continuous BTK inhibition is associated with a worse prognosis than patients who have a late progression beyond 5 or 6 years on a continuous BTK inhibitor. And therefore, even beyond TP53, this is a surrogate for aggressive disease, and therefore, typically, these patients will also not have an indefinite response to venetoclax. So generally, this indicates higher risk disease. So personally, in my practice, this would be patients, and the younger patients who very quickly progress throughout multiple lines of therapy whilst still being younger than 60 years. And for these patients, typically achieving disease control or sustained disease control is extremely challenging. And so for these patients, we still consider things like allogeneic transplant, which we did last year in I think 3 patients with CLL, because they had exhausted all treatment options fairly quickly, at some point also acquired TP53, but many of them also, independent of TP53, start off with a more aggressive disease. And therefore, I think it's important that we monitor and look at the disease dynamics in a sense of assessing when and documenting also when did the progression occur for these patients, so that it's evident that they were long or short responders, because, as I said, short response is always a risk factor in CLL.
Okay, and okay, I think maybe somebody is asking out of chat box, so we have something new from my colleague share with me. So how close are we to seeing BTK degraders or PROTAC therapy in clinical use for CLL?
Well, I think there's still a certain way to go. If I'm not mistaken, I think the degraders got a breakthrough designation or so, one of them at least, in the US in terms of the development. Generally, the challenge with the degraders is that there are several things that need to be addressed. First of all, they need to demonstrate sufficient activity and tolerability in of their own. And then the benchmark, in contrast to what we had before, is not how well does a BTK degrader work in double refractory disease, so in patients exposed to covalent inhibitors and to a BCL-2 inhibitors or progressing on those, but more importantly, what's their added value over pirtobrutinib or other non-covalent BTK inhibitors. Because at the moment, I would be so bold to say the standard of care for double refractory disease at the moment is pirtobrutinib, because simply the data are most mature and most robust for double refractory disease, more so than CAR-T cell therapy for that matter. And therefore, the benchmark is really pirtobrutinib. So I think we have to see that the degraders are more effective than pirtobrutinib in terms of duration of response, whilst having a similar toxicity or even more favorable toxicity profile. And so to do this, you naturally need randomized studies. The first ones are starting or have started, for that matter, comparing degraders to non-covalent inhibitors. But I think for having them in routine practice, I think it will for sure take still a few years until we have enough data. Certainly, though, because especially in the double refractory space, typically we collect events much faster than in other contexts in the first-line setting. I think the data will be there in not too far distance. Importantly, I think the degraders for me, where they will be also very interesting, is seeing whether they can act for triple refractory disease. So in patients who had received covalent inhibitor, BCL-2 inhibitor, and non-covalent inhibitor, because for these we don't have any options at the moment apart from experimental strategies or clinical trials. And so finding an opportunity to salvage these patients is, I think, something very meaningful that a degrader might be able to offer.
Thank you very much. And I think that we have time for the last question, if somebody would like to share anything. Okay, it looks like that it was the last question. So thank you very much again for this great discussion, also for the great presentation. And I am really thank all attendees to be here with us and vote in polling and also ask this question. So thank you very much once more time. And just to mention, this video will be available offline on our virtual platform and also on the Spotify. So if somebody will be interested to hear it one more time, to listen it. So we are going to share this link soon. So thank you very much.